Bismillahirrahmanirrahim. Today we'll start our fifth lecture on palpation for physical therapists. In this lecture, we will discuss how to palpate major structures in pelvis and thigh. So we'll start with the topographical views. In the topographical views, we can see some features. They are mentioned over here as well, like the iliac crest, the anterior superior iliac spine, inguinal ligament on each side, pubic crest, the bulk of the rectus femoris, and the prominence of patella. On the medial thigh, the vastus medialis can be seen. Then on the lateral side, iliotibial tract, vastus lateralis. The sartorius is an oblique muscle and it's the longest muscle of the body. It can be seen. The adductor region, the greater trochanter, the gluteus medius region, and the gluteal folds as well. In the posterior view, we can see in the midline the spinous process. Adjacent to the midline structures the erector spinae group of muscles. Then this is a very important landmark, the posterior superior iliac spine, PSIS. It is in line with sacral second vertebra. So S2 and PSIS are aligned. Then the iliac crest, the gluteal fold or the gluteus maximus region, the gluteal fold, the gluteal cleft, the coccyx, the hamstrings, the hamstring tendons, the popliteal fossa posterior to the knee. If you look at the skin and fascia is just proximal to the knee is thinner as compared to the tissue that is proximal or near the pelvis. Here you can see that the therapist is trying to passively extend the knee in prone position, and as the therapist is extending the knee passively, he can feel the slipping tendon of hamstring through his hands. So in this position, when the knee is flexed, the hamstrings they are more palpable and they are more prominent. But as you extend the knee, they become taut and tight, and thus they sink in. The gluteal region has fat tissue in it, and because of the presence of fat, it is not uncommon for this tissue to be cooler as compared to the other areas of the body. If we talk about the bone of the pelvis and thigh, so there is just this single bone in the thigh which is called as the femur. The pelvis is made by three bones, or it is sometimes referred to as two innominates. So the right innominate is formed by the ilium, pubis and ischium. Together these three bones make the iliac bone on one side and then another iliac bone on the other side. Anteriorly they are joined by the symphysis pubis and posteriorly they are joined by the sacroiliac joint on each side. These landmarks are very important because being a physical therapist you need to palpate a lot of structures. So if you try to palpate the symphysis pubis or the pubic crest, you need to travel in the midline just inferior to the umbilicus. So all the way down and above the genitals you will find the pubic tubercles and the pubic symphysis. Then lateral to that you can find the superior pubic ramus of the pubis. Iliac crest is the site where when you place your hands on your back, this is the most common site, and this is the site where the jeans is worn out and the belt is tightened. So there is an anterior process which is called as anterior superior iliac spine. It is on the front and a similar process on the posterior side. Now the bony landmarks and the pelvis and thigh. So here you can see the bony landmarks of pelvis and thigh in the posterior view. For example, similar to the anterior superior iliac spine, you can see the posterior superior iliac spine, and there is also a posterior inferior iliac spine as well. And as I mentioned earlier, that the posterior superior iliac spine is in alignment with second sacral vertebra or S2. So in the midline, this is at the level of S2. The iliac crest is in alignment with the spinous process of L4 most commonly, and sometime L5 also, but most commonly it is L4. Then you can feel the ischial tuberosities, they are deep to the gluteal folds, and in the midline you can feel or you can look for the coccyx, which is also called as the tailbone. And in the thigh, this prominence of the thigh is made by the greater trochanter. So on the femur there is a greater and lesser trochanter. So this is the tuberosity, or this is the tuberosity called as the greater tuberosity, and we have two trochanters over here. So the greater tuberosity is making this prominence, and there is a lesser tuberosity as well. Sometimes it is also called as trochanter, so the greater trochanter, and we have condyles down there, the greater trochanter and the lesser trochanter, or greater tuberosity and lesser tuberosity, used synonymously. Then we can look for the ischial tuberosities and shaft of the femur. The shaft of the femur is more palpable in the front region as compared to the posterior region. This is another view or the detailed view from the inferior aspect, and here you can see this is the pubic tubercle, which can be palpated just below the umbilical region, and then the symphysis pubis can also be palpated. The anterior superior iliac spine, anterior inferior iliac spine can be palpated. In the lateral view, again the same structures, but how you will see if you want to palpate them in the lateral position. For example, the patient is in sideline, or the patient is standing, or the subject is standing, and you want to palpate these structures in standing view or either in the sideline view, but from the side. So the most prominent part of this bone will be the iliac crest. So this is the iliac bone, and then on the anterior side you will find the ASIS. On the posterior side you will find a prominence which is PSIS, and similar all the structures that we discussed before. So again, all these structures that we discussed, for example, the ASIS and then AIIS, anterior inferior iliac spine, similar to that, iliac fossa, iliac crest. Then you can see superior pubic ramus, inferior pubic ramus. Then this is the symphysial surfaces of the pubis, the pubic tubercle, ischial tuberosity. Then this is the ischial spine, and just below the ischial spine you will find the lesser sciatic foramen, and above it will be the greater sciatic notch or the greater sciatic foramen. And then there will be this obturator foramen in this region. So and these are present on both sides. This is another view, and it is showing from the lateral side. We can see for this cavity, that is acetabular cavity. uh, the acetabular cavity is more of a horseshoe shaped. It is covering about 66% of the head of the femur, and it is further deepened by the acetabular labrum. There is a ligament inside over here that is not shown over here, but there is a ligament which is called the labral ligament or the ligament of head of femur, and that is providing the nutrient artery. And this is again important very clinically, because this can lead to, if there is a rupture to this ligament, this can lead to the avascular necrosis, and especially in the elderly. The sacrum and the coccyx. The sacrum is an inverted triangular bone. It is a bone which is similar to a triangle that is inverted, because it has the base above and the apex below. So the pointed surface or the apex is towards below, and base is towards the upper side. So it is an irregular bone. It has these foramens through which the nerves pass, and the sacrum is very prominent bone, uh, thus making the sacroiliac joint on each side. So you can clearly palpate the sacrum in almost everybody. The femur, this is the longest bone in the body, and it is one of the strongest bone in the body. People claim that it is stronger than steel bar. So it has a lot of attachment sites for the thigh muscles we are going to discuss in the muscle section. So again, the head, the neck, then there is the surgical neck, and then the greater lesser tuberosity of the trochanters, the shaft of the femur, and then the medial condyle and the lateral condyle. Then there is medial epicondyle, lateral epicondyle, and this is called the intercondylar groove, sometimes referred to as the patellar surface. And this is another view that is showing, this is the posterior view, this is the anterior view, and this is showing the gluteal tuberosity as well, because this is the site of attachment for the gluteus maximus muscle, gluteus medius muscles, and linea aspera. Again, this is the site of attachment to some soft tissues. So clinically important trail marks are the anterior superior iliac spine, iliac crest, and posterior superior iliac spine. Then the pubic crest, ischial tuberosity, and greater trochanter. Luckily, most of these structures can be palpated either in supine lying position or in standing position, or only this structure, the ischial tuberosity, is palpated either in standing or in prone lying, and rest of the structures except this greater trochanter, this can be felt with active or passive movement, with the movement of internal and external rotation. Other than this, all the structures are palpated in a static position or in the resting position. Here you can see the same structures, just the addition of iliac fossa can be seen. Rest of the structures are the same. This is the posterior view, and in the posterior view they want you to look for the tailbone, and in the tailbone I told you the PSIS is in alignment with the S2. You can find the S1 process or the sacrum. You can also find the posterior superior iliac spine. Then this portion in the midline where it has a few small projections, this is called the median sacral crest, because it is in the midline, hence it is called as median sacral crest. And edge of the sacrum can be seen over here, the coccyx, then the sacroiliac joint, which is very prominent on each side, and this uh, position is also marked with the presence of sacral dimples. So it has two dimples, one on each side, one right and one left dimple. So it has two sacral dimples as well, the sacroiliac joint on this region, especially on the upper part. And then on the trail 4 you can see the iliac crest, the greater tuberosity or trochanter, and the lesser tuberosity. ASIS, this is the simplest explanation to palpate how to palpate the ASIS and how the hands are placed on this. This is the iliac crest region, and this is again the position where you place your hands on your back, and hence the topmost part of the bone is the iliac crest. Then we have posterior superior iliac spine. It is the most prominent part of the bone on the posterior side, and just medial to this will be the sacral dimple. Pubic crest, if you place your hands obliquely in the inguinal region, then in the midline you will find this pubic crest. This is, again I must repeat, this is at least 4 to 5 centimeter superior to the genitals. The ischial tuberosity, it lies deep to the gluteal muscles and it can be accessed from these gluteal creases. The greater trochanter of the femur can be palpated by placing the hand on the upper lateral part of the thigh and then moving the femur into or the thigh into internal and external rotation. So this bony prominence come uh, will become very prominent with this movement, and it will keep on becoming prominent and sinking in. So when it becomes prominent, you will make sure that this is the greater trochanter of the femur. Then the anterior inferior iliac spine. This is a bit lower structure, but just adjacent to the anterior superior iliac spine and inferior to the anterior superior iliac spine. You follow the same trail down, and then this will be a bump in this region, and this is the anterior inferior iliac spine. It is the site of attachment for the rectus femoris muscle as well. This is how you palpate the iliac crest. You find the anterior superior iliac spine and the posterior superior iliac spine, and then you palpate the iliac crest. The iliac fossa is a bit deeper, and it is not possible to just move your hand all the way inside because of the presence of the pelvic structures and the muscles. But to some extent, if you want to go inside and you need your patient or you need your partner to cooperate with you, and with every inhalation and exhalation, you need to keep on pressing till you feel the middle or the medial surface of the iliac fossa, and this is the site of attachment for the iliacus muscle. Then the PSIS, all the way from the iliac crest down, you will find the PSIS. If you cannot find this PSIS, there is another simple trick that you will find the iliac crest. You will come to the midline where you will find the L4 spines process. Below it, you will find the L5 spines process, then the first sacral dimple, and then the second spines process of the S2 vertebra. So S2 is in alignment with this PSIS, and there will be a sacral dimple as well. The sacrum can be palpated in the prone lying position very easily. First, you need to find the median sacral crest in the midline, and then lateral to that, you can find the sacral body itself. The coccyx, this is the last part of the spine, or it is the smallest part of the spine as well, and it is very important clinically because it is famous for causing pain, and there is a condition called the coccygodynia or coccydynia. So that causes undue pain with straining of the pelvic floor muscles while defecating or even while sitting. So this is the tailbone, and these are 4 to 5 fused vertebrae, and sometimes they are not fused and they are independent to move. The sacroiliac joint can be assessed with this movement, the movement of internal and external rotation, because the piriformis muscle is attached directly to the sacrum on one side and to the femur on the other side. So if you press towards the medial rotation, then it pulls the sacrum upward, and hence you can easily find the sacroiliac joint on that side. Here you can see the sacroiliac joint. It is an irregular type of joint, and it is not a very plain joint. The greater trochanter can be palpated by moving the thigh into internal and external rotation. The gluteal tuberosity is just inferior to the greater trochanter, and this is again the site of attachment for the gluteal muscles. the superior ramus of the pubis. So it can be palpated just lateral to the symphysis pubis. This is the part of the bone that is lateral to the symphysis pubis. So first you need to find the symphysis pubis and then go lateral to it and you will find the superior pubic ramus. The inferior pubic ramus and ramus of the ischium can be palpated, but they are a bit deep and they are palpated from the anterior side as well as from the posterior side. So again, you need to find the symphysis pubis and then try to find out this part of the bone. This is the inferior pubic ramus, and if you keep on continuing on this path, you will find the ramus of the ischium, and underneath it will be the ischial tuberosity. The ischial tuberosity is most commonly palpated in the prone position. The patient or the partner is in prone position and you are pressing in the vicinity of the gluteal folds and you will find the broadest part of the ischial tuberosity there. In the hip flexion, it becomes more anterior because when we want to sit, this is the position when there is flexion of the hip and it causes the ischial tuberosity to become more anterior and superficial. When you are working uh, in the genital region, you can cover the genitals by some draping and then you can ask your patient to cover the genitals and keep you limited to the area being palpated. Now there are various muscles of the pelvis and thigh. The three gluteal muscles, they give shape to the buttocks and the lateral hip. 6 small lateral rotators are deep to the large gluteals. 4 quadriceps are located on the thigh, anterior and lateral surfaces. 3 long hamstrings, they lie along the posterior thigh. 5 adductors are tucked between the quadricep and the hamstrings along the medial thigh. So additional muscles are iliopsoas, serratorius and tensor fascia lata. Here you can see a lot of muscles can be named in this view. This is an anterior view. You can see the psoas major and psoas minor is present in about 40, I think 30 to 40% of population, most probably the 40% of population. And then this is the iliacus muscle. Together these are the hip flexors. This is the talar's muscle or the sartorius muscle. Then on the anterior side you can see the rectus femoris. Underneath it will be the vastus intermedius, then the vastus medialis and the vastus lateralis. Then the patellar tendon, the patella itself and the quadricep or the patellar tendon. So lateral to it will be the tensor fascia lata, and this is the iliotibial band to which the tensor fascia lata is inserted. And these are the gluteal muscles. And in the medial region you will find the adductor muscle, especially the adductor longus, gracilis and pectineus. This is the posterior view. Especially we want to focus on these two muscles, the hamstrings, the bicep femoris and semitendinosus plus the semimembranosus. So together the hamstrings, uh, the bicep has two heads, short head and long head, so two tendons on this side, and semimembranosus and semitendinosus, they have also two heads collectively, so four tendons they are inserting on the tibia and they are making the most prominent part of this region. Then the gluteal region, especially superficial to all the structures, is the gluteus maximus, then gluteus medius, then the gluteus minimus, and in the midline or the medial side, adductor magnus, gracilis, and rest of the muscles can be seen. In the lateral aspect, here you can see the tensor fascia lata muscle inserting onto the iliotibial band, and or sometimes referred to as iliotibial tract, the gluteal muscles and the hamstrings. This is the medial view and it is cut from the midline, so you can see the gluteal muscles, the ASIS can be seen, iliacus muscle, psoas major muscle, and here you can see a lot of muscles are attached to the ischial tuberosity, including the adductor magnus, then the semimembranosus semitendinosus, and similar to it, these are the muscles which are making the pelvic floor, the levator ani group of muscles. Obturator muscles can also be seen in this, and the piriformis can be seen. This is obturatus internus muscle. There is another muscle called as obturator externus, and the piriformis as it passes through this region. Here you can see the piriformis. It lies deep to the gluteus minimus, then the medius, and superficial to it is the gluteus maximus. Obturator internus and gemellus, it has inferior as well as superior gemellus on each side. Here you can see the same muscles, the piriformis, gemellus superior, obturator internus, gemellus inferior. Rectus femoris can also be seen over here, and the sciatic nerve passing through these muscles. So this is again, piriformis is a very important muscle clinically, because sometimes there are two variations in the pathway of the sciatic nerve. Either the sciatic nerve can pass underneath the piriformis muscle as a single nerve, or sometimes it pierces the piriformis muscle and then it passes through the piriformis all the way down. In either case, if the piriformis becomes tight or taut, then it compresses the sciatic nerve, leading to the piriformis syndrome, which is often diagnosed poorly. And then in this view, you're looking at the psoas major. The psoas minor is not shown over here. The piriformis, the gemellus superior, obturator internus, gemellus inferior, and quadratus femoris muscle can be seen. The perineum and the pelvic floor. The perineum is the diamond shaped area, and it is present at the inferior aspect of the pelvis. It is framed by the pubic symphysis, the ischial tuberosities, and the coccyx. A line drawn between the ischial tuberosity divides the perineum into two triangles. Here you can see triangle A and triangle B. The anterior, or the A, is called the urogenital triangle. It contains the external genitals, and the B, it contains the anus. Now the perineum and the pelvic floor is formed primarily by two levator ani and two coccygeus muscles. Here you can see the inferior view, or the superficial layer of the female pelvic floor, and the hip is abducted to show more of it. So these are the levator ani group of muscles, and then deep transverse perineal, and there is a superficial transverse perineal muscle. Then you have ischiocavernosus and the bulbospongiosus muscles. All of these muscles are showing the pelvic floor muscles. So being a therapist, you might be familiar of urinary incontinence, and in a lot of females you will encounter this problem. So the females can palpate to this region very effectively. Some other views showing how the muscles, how the layers are present, and how these hiatuses and foramens are pierced through the muscles. Another view. Now we will discuss the synergist muscles. For hip joint, it is also called as the coxal joint. There are a lot of muscles that can assist flexion. The major agonist, or the prime movers, are the psoas major and the iliacus. The rest of the muscles, the tensor fascia lata, the sartorius, rectus femoris, and other muscles, they are assisting. For extension, we have gluteus maximus. From fully flexed hip, the gluteus maximus is maximally active. Bicep femoris, long head, semitendinosus, and the adductors and the gluteus muscles, the gluteus medius, they are assisting it. Medial or internal rotators, the gluteus medius being the prime mover, gluteus minimus, tensor fasciae lata, adductor magnus, and some other muscles. It is important to remember that the piriformis muscle, it acts in as an internal rotator as well as abductor and as well as an external rotator in different positions of the hip. So this is lateral rotation. In the lateral rotation, you will find the gluteus maximus, piriformis, uh, quadratus femoris, and rest of the muscles. And the lateral rotators are more in number as compared to the medial rotators. And this is one of the reason when the patient is unconscious, then the hip is rotated externally. For abduction, the large muscles of gluteus maximus and medius, they are very potent abductors, and then we have gluteus minimus assisting them, tensor fascia lata assisting, sartorius assisting, and the piriformis when the hip is flexed. For adduction, we have adductor magnus, longus brevis, the three adductors, and the pectineus, gracilis, and gluteus maximus. For knee flexion, the bicep femoris, the semitendinosus, semimembranosus, collectively called as the hamstrings, the gracilis, sartorius, gastrocnemius, popliteus, and plantaris, all these muscles are working together. For extension, mainly the quadricep muscles, rectus femoris, vastus lateralis, medialis, and intermedius. In the medial rotators of the flexed knee are semitendinosus, semimembranosus, gracilis, sartorius, and popliteus, while there are only a single lateral rotator, and that is bicep femoris. The quadricep muscles are made by four muscles: rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius. And they are making the anterior part or the front of the thigh. All the bulk of the front of the thigh is because of these muscles. The most prominent muscle in this region are the rectus femoris, vastus lateralis, and vastus medialis. But some part of the vastus medialis is prominent because the rest of the muscle is present underneath the rectus femoris, and the, the vastus intermedius is covered with the rectus femoris, and it lies deep to it, hence it's not possible to palpate directly the vastus intermedius. Here you can see the quadricep femoris group collectively: vastus lateralis and vastus medialis. Quadricep as a group can be palpated if your partner is trying to extend the knee against resistance. The rectus femoris being the midline muscle, hence it is uh, easy to palpate this muscle in the midline while trying to resist the knee extension. And it runs just below the anterior inferior iliac spine to the patella. Vastus medialis is a teardrop shaped muscle, and it becomes very prominent when the person tries to squeeze the thigh or contract the thigh. So again, there's a condition called as the maltracking of patella. It is because of the wasting of this vastus medialis muscle, and normally in a healthy adult it should be bulging out. When the muscle is being contracted, this muscle should bulge out. But if there is wasting of the vastus medialis, then there is a dimple at this region, or it is less bulky as compared to a normal person or a normal side. So hence you can find out that the vastus medialis is weak. Vastus lateralis is more prominent and it is larger as compared to vastus medialis. So hence it promotes the supralateral tracking of the patella in the patellofemoral pain syndrome, and it becomes very prominent when you want to palpate it in the side lying or either in the supine position, and you need to perform an isometric contraction of the quadricep to make it more prominent. And it is deep to the iliotibial tract if you want to palpate in the lateral view. The hamstrings, the bicep femoris, semitendinosus, and semimembranosus, collectively 4 fibers but 3 muscles, because of the bicep has 2 heads, a short head and a long head. Here you can see short head and long head, outline of the short and long head. In this view you are looking at semimembranosus and semitendinosus. So collectively hamstrings as a group, you can get a hold of these muscles when the knee is flexed and the patient is in prone lying position. You can grasp these muscles and you can feel for their insertion in the ischial tuberosity. So ischial tuberosity is the site of attachment for these muscles, and then they are coming down to the tibia. Now here you can see the bicep femoris. The bicep femoris is on the lateral side and it has 2 bellies, the long belly and the short belly, or the long head or the short head. Semimembranosus and semitendinosus. Semimembranosus has more bulk and it has smallest tendon as compared to the semitendinosus. Semitendinosus has the longest tendon or larger tendon as compared to the semimembranosus. The gluteal muscles, they can be palpated very easily, especially the gluteus maximus muscle and the gluteus medius, some part of the gluteus medius as well. Here you can see how the gluteus medius is inserted, hence it is a very potent abductor. The gluteus maximus, so you can see this is the landmark, and if you want to palpate the gluteus maximus muscle with these landmarks, these are the coccyx, the posterior iliac crest, and then the gluteal tuberosity. Please remember that the gluteal tuberosity was inferior, or you can say distal to the greater trochanter. The gluteus maximus, if you want to resist the hip extension, then you will see the gluteus maximus contracting and becoming tighter and tenser. The gluteus medius muscle, the landmarks to palpate the gluteus medius are the posterior superior iliac spine, the iliac crest, anterior part of the iliac crest as well, and the greater trochanter. And you want to resist the abduction or perform the movement of abduction against gravity, and hence you can find the gluteus medius. For the adductors, we have adductor magnus, adductor longus, adductor brevis. Pectineus is also an adductor, and gracilis is also. So pectineus is a small muscle, then the gracilis is a bit large, and the rest of the adductors, brevis, longus, and magnus, are the other adductors. The pectineus, if you want to find out where the pectineus is, you need to perform an isometric contraction into hip adduction, and this will be in the most lateral part, and then you will find this adductor longus as well. The gracilis will be most medial and the pectineus will be the most lateral, and in between these you will find the adductor magnus, the adductor longus, and adductor brevis. So collectively, these adductors are making most of the bulk in superior medial part of the thigh, and you can perform an isometric contraction uh, of adductors by resisting the hip adduction, and you can feel the tensing muscles and then their tendons traveling all the way down. The gracilis is just medial and posterior to the adductor longus. The pectineus being the small muscle, as I told you that this is the most lateral part of the adductor group, and it is medial to the sartorius because sartorius is the most superficial muscle in the thigh region. The adductor magnus can be palpated deeply and in the midline, and it is posterior to the gracilis. The tensor fascia lata is very easy to palpate because this is present more on the anterior side as compared to the gluteus medius muscle. The gluteus medius is more present on the posterior and you can say some part of the anterior, but mostly on the posterior side and on the lateral side. But the tensor fascia lata is present on the anterior side and lateral side, so most of the portion of the anterior side is covered by the tensor fascia lata, and it is in contact with this iliotibial band, and you can also perform the movement of hip abduction and resist it to find for the tensor fascia lata. And again I repeat that this is anterior to the gluteus medius muscle. There's another technique that if you want to palpate the tensor fascia lata, you can also resist the hip rotation in the medial rotation. So when the patient or your partner performs medial rotation, you can feel the tensor fascia lata contracting a bit, and you can follow the fascia lata downward, known as the iliotibial band. The sartorius, also called as the Taylor's muscle, this muscle is very superficial muscle, and it crosses almost all the muscles on front and medial aspect of the thigh, and it has a lot of function, that is a flexor, it is hip abductor, external rotator, and knee flexor as well, knee extender as well. So this is one view how we can palpate the sartorius. In this figure of 4 position, you can resist the hip adduction or a movement of hip cross adduction or horizontal adduction. So then you will feel the tensing sartorius muscle superficially. If you place your hands just like this on the posterior knee, you will find the sartorius most lateral, gracilis, semitendinosus, bicep femoris, and the iliotibial band. Of course, the semimembranosus is deep to this. The lateral tendons are the bicep femoris, both heads, and the iliotibial band. The medial tendons are sartorius being most lateral, then medial to it will be the gracilis, and then medial to it will be the semitendinosus, semimembranosus being deep to it. The lateral rotators of the hips, the piriformis and quadratus femoral muscle, obturator internal and externus, gemellus superior and inferior, all these muscles are deep muscles. The piriformis and quadratus femoris, the piriformis cannot be palpated directly, but any pathology in the piriformis can be detected with palpation, and again it is a very deep muscle, so you need very strong hands to access the piriformis muscle. The quadratus femoris is again a small muscle and is a deeply situated muscle. The obturators, whether internus or externus, are again the deep muscles, and just a part of it can be palpated. Gemellus superior inferior small muscles cannot be palpated, but we need to know the location of these muscles. For the piriformis, you need to remember these landmarks: the coccyx, the posterior superior iliac spine, and then the greater trochanter. If you draw a T similar to this, or if you draw a line, then come to the midpoint of this line, and then from that point draw a line towards the greater trochanter, and you will find the piriformis underneath this location. With the movement of internal and external rotation, you can either tense or relax the piriformis muscle. The quadratus femoris is a small muscle and it's deep muscle, so just lateral and inferior to the ischial tuberosity you will find its location. The iliopsoas, collectively they are deeply situated muscles and they cannot be palpated directly. The psoas major and iliacus, both the potent hip flexors. Psoas minor, it is present in about 40% of population. Psoas major, it lies deep and it has attachment site to the bodies of the lumbar vertebra and transverse processes of the lumbar vertebra, and then it inserts on the femur. So it is deep muscle, and if you want to palpate you need to resist the hip flexion, and it is most medial to the inguinal ligament. Here you can see in the sideline position the patient is trying to the therapist is trying to palpate the psoas major on the subjective patient. Iliacus, again this is a deeply situated muscle, and some part or upper part of it can be palpated, but with caution, and if the patient is skinny you can do it. Here you can see how the therapist is trying to make hold of this muscle, and you need to go inside either with the help of your fingers or with your thumb. The patient needs to be in sideline position. The inguinal ligament, this is a very prominent part, or sometimes referred to as the groin area. This is very important part, and this is the, you can say, making a boundary or site of attachment between the lower extremity and the pelvis, so, or the abdomen. So this is the inguinal ligament, and again this is very palpable, and it is continuous from the anterior superior iliac spine to the pubic tubercle. These are the references. Now we will move to the question and answer sessions. Thank you very much for staying put.